So our next speaker is Dr. Percy Griffin from Alzheimer's Association. And as I said earlier, it's really nice to have people from all different areas who are interested in this disorder. So Dr. Griffin is the Director of Scientific Engagement for the Alzheimer's Association. His background is that he holds a doctorate in molecular and cell biology from Washington University. And today, he will be talking about advancing health disparity research in ADRDs, efforts from the Alzheimer's Association. Dr. Griffin.
Thank you so much for that introduction. And also thank you to the organizers for allowing me an opportunity to present here today. I apologize that I can't be there in person, but as was introduced, I'm going to present on some of the efforts, the ongoing efforts from the Alzheimer's Association to help advance ADRD health disparities research. And I can see that you can see my screen, so I'm just going to be advancing slides. Okay, perfect. That's advancing. So I have no disclosures except that I'm a full-time employee of the Alzheimer's Association. Now, just to get started, I want to flash up this slide here and mention that the Alzheimer's Association is a global voluntary health organization that is leading the way to accelerate research, drive risk reduction, and early detection and diagnosis to maximize quality care and support. And our work is about the people and the science. That's what is seen in our logo here, just to kind of ground us to where this conversation is going. Now, to accelerate the science, we fund. We accelerate global Alzheimer's research through our funding, and we're the largest nonprofit funder of Alzheimer's and dementia research in the world. We currently have more than $320 million active across more than 1,000 projects in 54 countries. We fund in areas where people can't or won't fund, and we're trying to accelerate the science to make sure that earlier, riskier ideas can be given an opportunity to be advanced in a way that that may help tackle this devastating disease. Now, as part of our funding programs, we have our four core funding programs, which are our core programs, which open twice a year. Now, this is funding that goes to early career researchers who have completed a terminal degree, so a PhD, an MD, that kind of thing. And this includes our Clinician Scientist Fellowship, our research grant, the Research Fellowship, and the Research Grant New to the Field. Now, for each one of these grants that are shown on the slide, we have an analogous one that is to promote diversity in the field. We understand that there is, the diversity of the research is just as important as the diversity of the researcher. So we want to advance both of those. And these grants, the grants to promote diversity, make up 25% of our current portfolio. Now, just a level set here before I proceed through the rest of the talk. Each year we release our facts and figures report. Now, it's a very informative document. We just released the 2023 version last year. And as always, just to give some numbers on Alzheimer's disease, there are currently more than 6 million Americans aged 65 and older living with Alzheimer's. The number is actually up to 6.7 million. And this number is expected to more than double to 12.7 million by 2050. 1 in 3 seniors dies with Alzheimer's or another dementia, and it kills more people than breast cancer and prostate cancer combined. Now, between the years 2000 and 2019, while the deaths from other conditions such as heart disease and cancer have gone down or remained flat, deaths from Alzheimer's have increased by 145%. We also know that care partners are heavily impacted. In 2022, more than 11 million Americans provided an estimated 18 billion hours of unpaid care, which is valued at $345 billion. This was for people living with Alzheimer's or another dementia. And we also know that this continues to be, this is a global problem. We know that the number of people with dementia globally is nearly expected to triple to more than 152 million by 2050. So these are just some numbers from the Facts and Figures report, which is published every year. And this year we also took a look in our special report to understand some of the barriers that individuals are facing while trying to access a treatment. So we looked at the patient journey from two perspectives. We looked first at through focus groups to understand why there's some hesitance to communicate cognitive complaints to primary care physicians. And we also took a look at the physician capacity. So dementia provider specialists, what their capacity was. And on both fronts, we found that there were some significant barriers. So if you get a chance, take a look at that special report. Now, again, to talk a little bit about the continuum of the disease, so researchers understand that that cognitive impairment occurs across a continuum. Now, this spans several years, and as we age, all of us will move through some phases of normal cognitive aging. So this is a natural process, and there's some small changes to cognition over time. But Alzheimer's, what we're talking about here, is a process driven by disease, by disease biology and changes to the biology in the brain. So typically we all start off, cognitively unimpaired, but there's this asymptomatic phase where some of the biological changes associated with the disease have already started happening. So the deposition of the amyloid and tau, and this has been shown to happen about 20 or so years before the clinical onset of the disease. Now, some individuals will then move into the mild cognitive stage of the disease. Now, this is mild cognitive impairment due to Alzheimer's disease. Now, this is the earliest clinically detectable stage of the disease. And some individuals who do get MCI due to Alzheimer's disease will progress to dementia due to Alzheimer's disease through the mild, moderate, and severe stages of the disease. Each one of these being associated with increasing levels of cognitive impairment. Now, considering all that we know about this continuum, it's still interesting to say that we've made tremendous progress, but we don't fully know what causes Alzheimer's yet. However, researchers each day are making tremendous discoveries that will help us answer that very question one day. Now, the factors that impact the risk of developing Alzheimer's broadly fall into two large categories. First are the non-modifiable risk factors. So we have age, genetics, race and ethnicity, as well as sex and gender. And then we have the modifiable risk factors, things like education, traumatic brain injury, how much physical activity that you're getting, sleep, diet, and I'm sure other speakers have also touched on this during this conference. But while these are called modifiable risk factors, they may not be changed so easily. Now, the overall risk for an individual is a result of these complex interactions of both the modifiable and non-modifiable risk factors. And we also know that coming into the fold is the increase in our understanding of how these social determinants of health may impact some or all of these factors, and underscoring the need for us to study the disease from all angles. Now, one of the big things that we need, considering all of the contributors to risk, as well as this continuum that I just talked about, are tools for early detection and diagnosis. Now, for almost 100 years from when since the disease was described, the only way that was possible to make a diagnosis was at autopsy. But in 2001, Bill Klunk at the University of Pittsburgh developed amyloid PET imaging, which allows us to take a look at people's brains while they're still alive. And now we're on the cusp of accessible blood biomarkers that look at the amyloid, the tau, the GFAP, and the phosphorylated tau species that can help with staging this disease. Now, other emerging tools are also looking at things like the eye and other biofluids, and these are all under active investigation. Now, given the importance of this amyloid PET imaging for the diagnosis of Alzheimer's disease, we sought to understand what the utility of this amyloid PET imaging was. So the Alzheimer's Association collaborated with the Centers for Medicare and Medicaid, as well as the American College of Radiology, and launched the IDEA study, Imaging Dementia, Evidence for Amyloid Scanning. Now, this sought to understand the utility of amyloid PET scans, and the study included over 18,000 Medicare beneficiaries with mild cognitive impairment or dementia of an unknown case. Now, it was found through the study that clinicians were twice as likely to prescribe Alzheimer's drugs following PET imaging to participants with MCI and positive amyloid brain scans. And a surprising 2/3 of participants had a change in their diagnosis and/or care management as a result of these PET scans, demonstrating the utility of these PET scans in clinical care. But we know that Alzheimer's does not affect everyone equally. Almost 2/3 of the Americans with Alzheimer's are women, and we still don't fully understand what is at play here. Now, in 2021, we had a special report that looked at discrimination as a barrier to getting care for dementia, and I'll touch on that later. But we also know that older Black Americans is twice as likely, and older Hispanic Americans are 1.5 times as likely as older whites to have Alzheimer's and other dementia. This may be driven in part by underlying cardiovascular health factors, but also related to the social determinants of health that I talked about. Now, there's a huge underrepresentation of these populations in clinical studies. So if we take a look at ADNI, for example, initially less than 5% of the participants were Black or Latino. And I know that there are efforts now to kind of increase that. Furthermore, when they, in previous studies that have surveyed Black and Latino participants, they found that they were 64% and 44% less willing to be contacted for clinical studies than white individuals. So we need to study what drives dementia in all people, so that these results are generalizable to our diverse communities. Now, in the IDEA study, we had over 17,100 individuals who had amyloid positivity based on the scans. Each participant received 1 scan. And the amyloid, we also looked at the positivity of, we compared the diverse cohort, that was recruited in IDEAS who also had amyloid positivity. However, what this graph here shows is that a very, very small percent of the participants were actually non-white participants. Although this was a fairly large cohort, it was still a very, very small number of individuals. But a recent paper that was also published found that there were ethnic and racial differences in amyloid PET positivity in individuals with MCI or dementia. Once again, underscoring the need for greater inclusion in these kind of research studies. So also from the IDEA study, this graph here shows the level of impairment by different races and ethnicities. Now we find that white and Asian participants are coming in for diagnosis earlier, and therefore are more likely to be diagnosed in the mild cognitive impairment stage compared to Black and Hispanic individuals. Especially now that we have treatments that are aimed at that are looking at the early stages of the disease, we need to drive early detection and accurate diagnosis for individuals from all communities and not just some of these communities. So building on the learnings from the original IDEA study, the Alzheimer's Association launched the new IDEA study. Now, this study will assess the utility of PET scans, PET scan results in diagnosing and treating memory conditions in participants of diverse racial and ethnic backgrounds. And as you know, we don't have a lot of information in these populations. And from the original IDEAS paper, we know that compared to whites, Black/African Americans and Hispanic/Latinos have a 50 to 100% higher rate of dementia. We also know that our U.S. population is aging, and in 35 years, 1/3 of the U.S. population over the age of 80 will be Hispanic, Black, Black or African American, or an ethno-racial minority. So in the IDEA study, the target recruitment goal is, the new IDEA study, excuse me, the target recruitment goal is to have 7,000 participants, 2,000 of which will be Black/African American, and 2,000 of which will be Hispanic/Latino. And we also seek participants with diverse dementia presentation as well. So we're working with experts from several institutions who have researched the science of recruitment of underrepresented populations for decades. So Dr. Peggy Dilworth Anderson and Dr. Consuelo Wilkins are nationally recognized leaders who are part of the leadership team for the new IDEA study. So what's important to emphasize here is that we're building a new methodology while we're implementing it on a grand scale in our field in the new IDEA study. Now, community engaged research is an effective strategy to form effective relationships and with individuals from these underrepresented communities. And so we've recruited study champions from these communities who go out and deliver talks about the study as a trusted resource. We're targeting large metro areas, including Washington, D.C., Chicago, Dallas, Houston, LA, Miami, Philadelphia, and San Diego. Now, this is work that is being done in partnership with the Alzheimer's Association chapters, and we're also working on a national level to increase the awareness of the study, to make sure that the recruitment materials as well are not just translated, but transcreated in a culturally sensitive and appropriate way that resonates with the communities. And we're also working with the experts and the imaging facilities to identify and enroll individuals from these underrepresented backgrounds. Now, as of last month, in terms of recruitment, we've recruited over 4,000 individuals for the study, with 121 activated PET imaging sites and 146 activated dementia sites. So I wanted to talk a little bit about a study that came out of our international meeting, the Alzheimer's Association International Conference last year. And we've known for a while that racism can affect the mental and physical health of millions of people. But this work found that experiences of structural racism was associated with lower episodic memory among all ethnicities that were studied. Additionally, exposure to interpersonal and institutional racism was also associated with lower memory scores, and this was driven primarily by the Black individuals in the study. So this again points to the importance of taking a life course perspective when you're thinking about doing some of these studies. And individuals from who were over the age of 90 from all races who had experienced wide-ranging discrimination throughout life had lower semantic memory later in life compared to those who had experienced little to no discrimination. So the big takeaway here is that racism is a traumatic experience, and it causes increased stress. This can lead to some of the negative biological consequences, such as inflammation, which we know can contribute to neurological changes in the brain that lead to neurological disease. But all of these are large issues that were reported out in our international study, our international conference last year. So we also, to better understand these racial and ethnic disparities in Alzheimer's disease research and care, in 2021, the Alzheimer's Association conducted 2 nationwide studies of US adults and Alzheimer's caregivers. This was the first time ever that Asian, Black, Hispanic, Native, and White Americans had been surveyed on the topic. So we sought to gain a deeper understanding of and insights into the barriers that these diverse populations are facing in accessing and receiving dementia care. Now, this special report was particularly eye-opening. So what did we learn here? So we learned that there's a need for healthcare providers who understand the unique experiences and backgrounds of people of color. However, many people from diverse populations doubt that they'll have access to culturally competent providers. And there's also varied knowledge, awareness, concern, and stigma about Alzheimer's across different racial and ethnic groups. And there's a real lack of trust in the research process, which is a significant hurdle which must be addressed. So from the survey, we found that more than 1/3 of Black Americans and nearly a fifth of Hispanic and Asian Americans believe that discrimination would be a barrier to receiving care. Now you can see this here. You can see this here highlighted on the slide. Now, in practice, actually, the situation is even worse. Half of Black Americans report experiencing healthcare discrimination, and at least 1/3 of Native Asian and Hispanic Americans also report the same. Now, one of the biggest concerns that was identified by Black, Hispanic, Asian, and Native Americans was that they felt as if providers were not listening to them. So this again points to the importance of culturally competent care for individuals from these underrepresented populations when it comes to providing dementia care. So we also know that people from underrepresented backgrounds in this survey mentioned that they want providers who understand the experiences and their backgrounds. That's seen in the purple bars here. However, seen in the blue bars is we find that they doubt that they have access to these culturally competent providers. Now, again, in this survey, what we found is that nearly 2/3 of Black Americans believe that medical research is biased against people of color. This is a view shared by a substantial number of Asian, Native, and Hispanic Americans. Now, there's a lot of this just points to the mistrust that exists in medical research and may start to explain why we've had major hurdles in recruiting diverse populations into clinical trials. Now, even more shockingly, only half of Black Americans trust that a future cure for Alzheimer's will be shared equally regardless of race, color, ethnicity. Now, emphasizing the need for a new science of recruitment and retention, which is part of what we're working on in the New Ideas study. So we also found that knowledge, awareness, concern, and stigma about Alzheimer's varies widely across racial and ethnic groups. Concern about developing Alzheimer's is lower among Native Americans, Blacks and Hispanics compared to whites. Over a third of Native Americans and nearly 3 in 10 Hispanics do not believe that they'll live long enough to develop Alzheimer's or another dementia. And more than half of non-white Americans believe that decline in cognition and memory are just a part of normal aging. This is part of why we did the special report last year looking at trying to raise awareness to mild cognitive impairment being not just normal aging, but being the earliest stage of the disease in our special report entitled MCI, not just normal aging. So to shift gears while in closing here, I want to talk briefly about the efforts from the Alzheimer's Association regarding risk reduction. So in 2020, the Lancet Commission published a report, and they said that up to 40% of global dementia cases could be prevented or delayed by targeting modifiable risk factors. Now, given this, one of the big questions that we have to answer is, what would happen if we layered on additional components to a lifestyle intervention approach to reduce the risk of cognitive decline? This is why the Alzheimer's Association is conducting a landmark multi-domain lifestyle intervention clinical trial in the US called the US Pointer Study. Now, this is the first trial of its kind to be conducted in the US, but it builds off a successful trial that was conducted in Finland called the Finger trial. The Finger trial found that a multi-domain lifestyle intervention approach can reduce the risk of developing cognitive decline in elderly at-risk Finnish population. So the US Pointer study will test whether two lifestyle interventions encouraging physical exercise, a healthy diet, cognitive and social activities, and health monitoring can reduce the risk of memory changes in older adults at risk for memory loss. So the two lifestyle interventions being compared are the self-guided and the structural group. Now, this intervention is taking place over the course of 2 years in 2,000 participants across 5 geographically diverse sites. Now, positive results from the US Pointer study will inform an accessible and sustainable community-based lifestyle program for risk reduction. Now, I'm pleased to announce that all 2,000 participants of the US Pointer trial have been enrolled, and this study achieved 30% underrepresented population recruitment by employing some of the community engagement strategies that we had discussed here. I discussed earlier. Now, in closing, we know that. Yes, I'm closing out. Yep.
3 more minutes.
Yep. I'm going to close. There's my last 2 slides. So in closing, we know that awareness of clinical trials remains a challenge for getting involved in these clinical studies. It's why the Alzheimer's Association introduced Trial Match, which is a free clinical trials matching service. We have over 300,000 users, and it's one of our ways to help push the urgent need for inclusion in these clinical studies. So in summary, we know that we need more research to understand what is driving risk across all different populations. We also need to encourage early detection and accurate diagnosis to help maximize care. And individuals from underrepresented populations want providers who are culturally competent.
Great. So,
Yep.
We may have time for one question.
Screen got disconnected, but thank you.
Here we are. We got a question.
Yep.
Thank you. You've talked a lot about the different underrepresented communities, and I was thinking about the 2/3 of the population, the women that have Alzheimer's. Are you also looking at that in all of your studies that you're currently planning to see what's driving that other than just longer lifespan?
Yes, so actually what we find in a lot of studies is that the women do sign up more for clinical studies. I think the number is actually over 70% of all of the participants are women. So that is also being that is not by design. It's just what is known across the field. So we're definitely investigating that more, and we have specific targeted funding programs that are looking at sex and gender differences in some of the biological changes that happen with that happen when someone is having Alzheimer's disease. So we're investigating that on several angles, including through our funding as well.
Thank you.
Thank you.
Chat? No.